well. So just wanted to acknowledge our team there for sure. So I will turn it over to Dr. Shalsha, our Chief Medical Officer. Just in this progression, the legislation passed in 2019. There was a board resolution in 2020, a bylaw change in 2020. Dr. Shalsha joined us as our Chief Medical Officer in 2021, and I think you all are familiar with some of our initial direct practice areas like surgical podiatry that started quickly thereafter in January of 2022. So you can get a sense of the progression of the healthcare district, and this really allows us to operationalize a lot of the health equity action plan that you all recently adopted, and a lot of the services that are anticipated even for the upcoming year at Rosewood Zaragoza and the skilled nursing facilities and a lot of these other services that we've talked about in other meetings. Alan?
All right, thank you. Good afternoon, Board of Managers, and I have to say I'm really excited to share kind of the infrastructure and the build that we have to date. The Medical Executive Board, or our MEB, as we know it as, structure sits in front of you. The boxes, the first line that sits under our MEB are our committees that I'm really going to focus on, especially the four at the right, so credentialing, policies, procedures, and protocols, quality, and our P&T committee. We have, this is the infrastructure we have set up, but we are not meeting on a monthly basis as related to our utilization and peer review committee. Utilization really speaks to the cost effectiveness of, of the practice of medicine, and considers our daily, our weekly, and our monthly methodology. We do speak and consider utilization, but right now we focus on utilization within our quality infrastructure, and I'll speak to that as we mature as a system. So utilization will build up and we'll meet monthly specifically for that purpose. Our peer review speaks directly to our direct practice of medicine, and so though that committee has been set up, I think we're 40 days to the day of opening, our specialty clinic, followed by the next couple of weeks that other direct practice methodologies. And so, our peer review committee is an environment where when we conduct chart audits, where we look at efficiencies and behavior of providers, that is a protected environment where we can discuss those issues. And so that will obviously be stood up, with be functional with our direct practice of medicine. I'm going to touch on some of our subcommittees and work groups because I'm not going to spend a ton of time on them. We're really going to focus on the committees. The subcommittees and the work groups that you have sitting in front of you report up to our quality committee. Actually, we can go back one slide, please. Thanks. So I'm just going to briefly describe them. Care model subcommittee. Care model is really describes the way we practice medicine. It is everything from the method that we conduct medicine. So is it a video visit? Is it a telephone call? Is it an in-person visit? What do our MACs do when patients enter the front door? What are the roles and responsibilities of our MAs? What are the roles of our providers? Where are they going to be documenting? When people access MyChart, who is the pool that is going to receive those messages? What are the expectations of our care teams as related to returning those messages? It is everything. It is the entire infrastructure of the practice of medicine. And you can see reporting up to that is Epic. Epic is our electronic health record system. So the tool that we utilize to practice medicine, obviously that is a part of our care model. And so those two work really closely together. For safety and infection control, this subcommittee really focuses on exactly what the title says. So if there are immunization errors, if there are opportunities to align and create uniform processes for glucose checks, when we look at sterilization, if there is a patient fall in our environment, all of that falls under the oversight of our Safety and Infection Control Committee, antibiotic stewardship. So that is a pretty broad committee that then reports up to our Quality and Improvement Committee. Our Education Work Group, we stood this up before we opened the practice of medicine due to its critical importance. When we provide educational materials to our patients, we need to ensure that those educational materials are coming from a source that is dependable, right? So I'll give an example. If we're looking at heart failure and our community health worker is giving educational resources to our patients, number one, are we utilizing American Heart, right? Is the language that we are sharing with patients understandable and appropriate? What is the scope of the person that is sharing that information, and is it within their scope? For community health workers, they're critically important, to our system, but they can't practice medicine. And so that infrastructure is set up really to help support the information, to standardize, to make sure that there's no copyright infringement, that we really are representing Central Health the way we all would want Central Health to be represented. And so information will be vetted there and then transitioned out. Next slide, please. All right, now we can really start having fun. Pharmacy and therapeutics. So Pharmacy and Therapeutics Committee is the committee where we look at our formulary, right? What med additions would we like to add? Which ones would we like to remove? What are the doses of the meds? Are the meds that we're adding specific to a condition? Are they in contradiction to either policy or procedure, that we have enacted here? And so this is a very active committee. This committee meets quarterly. If you look at the colored delineation that sits before you, our voting members, our physician voting members are delineated in blue. Our significant stakeholders are in the pinkish purple. And then we have some other subject matter experts that are kind of in the, what is that, aqua color. As you can see with our Pharmacy and Therapeutics Committee, we have outside stakeholders that participate in that committee because it's the Central Health Formulary. So we've got Lone Star and Peoples and community care individuals who sit on the committee and weigh in. Next slide, please. The workup for the presentation or for our actual meeting actually takes between 4 to 8 weeks to prep. There's a lot of data that has to be collected. Which are the most frequent clinical diagnoses? Which meds are we missing? Is there a new med that is now affordable, that is available, that is more efficient, that is a once-a-day med versus something that patients are taking 3 times a day that decreases, their chance of success? What is the affordability of the med for us long-term? How many people will be affected by this med? And so there's quite a lot of research that goes into the presentation on pharmacy and therapeutics. In addition, if we go to the next slide, please, we discuss the actual monograph, so the pharmacology of the medicine itself, right? What's its time to onset? What's the mode of intake? Is it contradictory for any patient populations? Is it contradictory to any other medications that that would be taken? This is an example of fluoxetine Prozac, which is an antidepressant. But we will go through these discussions just in order to make sure that these medications are really safe to our patients. All right, next slide, please. Credentialing committee, this is specific to our direct practice of medicine and to our network providers. This meeting occurs monthly. The makeup of the committee, the colors are delineated exactly the same as in previous committees. So you've got your voting members, your significant stakeholders, and then your subject matter experts that will sit within this committee. Next slide, please. When we consider credentialing somebody, we look as to ensuring that they've completed their education. We have to look at their internship and their residency training. We have to obtain information from every previous employment location that they have had. If there is any board citation that they've had, we have to look at that. We have to consider if they're board eligible or if they have board certification. And so what the committee subdivides individuals into, if there are no potential red flags, in the providers or organizations will be transitioned and approved. And then if there's any need to dive a little bit deeper into either the training or things that have occurred, over the span of time, the committee will then, do a deep dive into that. Next slide, please. Policies, procedures, and protocols. Obviously, when you stand up the practice of medicine, there are hundreds of policies, procedures, and protocols that have to be considered. The policies are really specific to the practice of medicine. And the policies transition through the PP&P committee, and then as with our other committees, there is a recommendation made to the MEB for approval and adoption. The work that goes into this is just as you all would think it occurs. There are months of delineation and research that occurs beforehand. Subject matter experts have to weigh in. We have to ensure that the policies, procedures, and protocols are not contradictory to purpose or to organization. And then they're brought for a vote. Not every procedure or protocol is brought forward. Now, there's a very similar process that is not as that doesn't have to enter the PP&P committee, to ensure that those procedures and those protocols that we have our subject matter experts weigh in, and again, that we are following proper guidelines, within our clinical environments. All right, next slide, please. All right, we can jump one more. Quality assurance and improvement. I love all of these committees. This is my favorite. This is our environment where we can ask questions, right? So when we have quality and performance improvement or process improvement, this is not a report out committee. And you can see that the membership of this committee is significantly larger because we have many stakeholders within our organization. These stakeholders sit on these committees. This is our environment where we either ask we ask district questions as far as clinical environments that we should be working in, quality environments that should potentially be improved, should they be contracted for, should we concentrate on direct practice. What we have tried to create within our quality and performance improvement environment is a safe space where we can actually ask questions, where we look at barriers to care, where we consider health equity. And if we can go to the next slide, I can give a little bit more information. So we calendar between 6 months and 12 months ahead of time. Again, looking at areas where we either have critical need, either in our direct practice or throughout our district. And various subject matter experts are then invited to present. Their presentations are due to us, I think, 6 to 8 weeks in advance. And we sit as a much smaller group with those presentations. We have our Director of Health Equity sitting at that table, and then other SMEs, so that we can go through that presentation, see if there are any potential holes in the presentation, and ask critical questions. If we do see potential barriers to care, we can ask the presenter ahead of time before they get in front of that much larger audience, to provide that information. We also look at the data. So if there are potential questions to that data, if there's additional data that's needed, that group will then, request the data so that when we finally get in front of that much larger group, the that is a prime opportunity to have subject matter experts with different paradigms weigh in and provide information, thoughts, questions, and again, with our goal of really challenging the status quo, and hopefully directing either what we contract for in the future or what type of practice we directly provide. Next slide, please. And we can go to the Medical Executive Board. Actually, sorry, can we go back one? Thank you. We just wanted to show some examples of the topics that we have discussed within our Quality and Performance Improvement Committee. Now, because we have outside stakeholders come and present, and many times we are presenting, or they are presenting, or seeing information that is pertinent only to their organization or to another organization, so NDAs do have to be signed, and that information is protected. Some of the topics you see have, we've visited twice, and that's because we've learned a lesson, we've adapted that lesson, and then we've brought it back to see if we've actually affected change. We've brought pilot programs. We run a pilot, we need to know, is the pilot actually achieving what it's set out to achieve? And if it's not, does it go away? Do we augment it? If it is, how do we actually roll it out, increase its scope, or roll it out fully? And to our Medical Executive Board, please. All of the committees roll up to the Medical Executive Board. So the motions, if they're approved, are advanced on a monthly basis to the MEB, and our voting members will then, transition vote on the motions, either approve or not, or transition or augment those motions. As happens with the Board of Managers, the lineup to the MEB is critical, because if there's a delay in credentialing of a provider, and that doesn't make it to the MEB, that could potentially delay access for patient care for a month or two, based on when we get those providers credentialed. So there's a lot of, as John mentioned, there's a lot of work, a lot of effort that goes into the preparation of these committees, and the topics, the subject matter, and the information that is shared, conveyed, discussed, is quite a lot. And I think we can take questions either here or potentially in closed session.
Thank you so much, and congratulations for this. This is great, great for Central Health and for our community. I have a question, two questions. Mine is more of about structure. So if it's clear to understand our role as a committee member of the medical, what is our role into this, knowing that you have your subcommittees, it'll be helpful for us to know. And I know giving the legislature where we can intervene and where we can't. So if you can delineate that for us, it'll be helpful. And my other one, just really quick, is I'm just curious, on slide 17, the topics that were presented, patient experience and financial advocacy. How do those two interrelate?
Was that our quality?
Those,
Quality assurance
yes.
and improvements, the 17.
Okay. So
Thank you.
are
Those
you
my
okay if I
questions.
take that one first and then, okay. So I had said that within our Quality and Performance Improvement Committee that we didn't really do report outs. They were really an opportunity to dive in, to see how, to get in the kitchen. There were a couple examples that don't sit exactly in that environment, and one of those was looking at one of our demographic reports, and the other one was looking at kind of patient feedback. We really thought it was important for the individuals who are sitting in that room who are prepping a new healthcare system to understand what patients were feeling, what their feedback were, where their challenges are, what their health needs were, where the gaps were in the system. And so those were a couple external presentations that it was a diverse audience and significant stakeholders who were right now directly responsible for the preparation of the system that we are, all advocating for. And so they needed access, they needed to hear and see what some of those opportunities and challenges were.
And if I could just add to that a little bit, Manager Musaitif, that's one of the areas that we're building on related to direct practice. Up to this point, that function's really lived in our eligibility services department, where we would receive patient concerns or complaints, or, some could be related to their interactions with Central Health. Some of that could be related to interactions with a network provider. And so we've got a function that we're building on related to direct practice that continues to monitor those complaints and advocate for patients where we need to. And that could be on a variety of issues. It could be on something related to billing. It could be a patient experience in a clinic. It could be a quality or an outcome concern that's brought to our attention. So this is trying to create structure around that and make sure that we're properly advocating for our patients.
That's wonderful. I'm glad to hear that it's comprehensive. It's not just from the financial aspect of it. Thanks for that. And my first question?
I think we'll probably be able to better answer your question in the closed session part of the meeting, if that's okay.
Sure.
Okay.
However you recommend. Thank you. Thank you.
No, I think I'm asking it in closed session.
I just have one question. So what I saw up on the board are mostly Central Health Community Care staff that are going to be on this board, on these committees?
No, the majority of, or almost all of the staff on these committees are Central Health staff, with the exception of our pharmacy or pharmaceutical and therapeutics committee, in which case we have external stakeholders that sit on there. They're non-voting members, but they're subject matter experts that weigh in.
And that goes back.
You have two
Oh, go ahead.
incredible, experienced people who set up a P&T committee from the very start. Dr. Bell and myself, that's when we met 20 years ago, when we set up the state P&T committee.
And it was fun from that moment on. You never looked back.
And as I fell in love with that man.
You're correct,
I
Alan.
fell in love with this man because he is an incredible mind and so knowledgeable, not only about healthcare, but about the finances of healthcare. This man taught us so much in those committees. So wouldn't it be great to have board members in there as well?
Well, that is where I think we will defer to
Yeah.
legal counsel.
So, Chair Zamora, why don't we take that up?
Oh, sure,
in
no problem.
closed, Okay,
Understood.
thank you.
I have a follow-up question.
Manager?
Thank
Clayton?
you. So follow up on that, can we have the names of those who are in your subcommittees? I know that you have their titles, but it'll be helpful to know who they are as well.
I think one of the opportunities, so as long as council doesn't object, I think we would love to share that. We were hoping, I think we've been able to share some of the diverse specialty knowledge that we've been able to bring on board, and just diversity in general. And so I think if there's an opportunity to actually show who those members are, maybe we could include some of their bios, so that you all can really get a sense of, who sits within that MEB.
That'll be wonderful, thank you.
Manager Valdez?
These are just
Push the button.
two basic questions. I apologize for walking in a little late. I was in another meeting. With respect to the medications that each of the patients are receiving, if it's a period of time between doctor visits, or they see another doctor that may not necessarily be part of the network, how would you be getting that information? And who would be monitoring whether or not the different meds, how they're interacting with each other, and how that's impacting the organs of that person over a period of time? That would be one. And the other is, with respect to the home environment, if our population, has to make a decision as to whether or not we're gonna pay the rent, or we're gonna buy groceries. Are we going to go buy the medicine, or are we going to just let it, those kinds of questions? Is anybody, is a community health worker working, up in charge of that, or the social worker? How is that being monitored? Because it's easy for a doctor to be able to, okay, this is what we're prescribing for you, this is gonna be hopefully what your action plan is gonna be, and may not necessarily have access to the information, the real information that the patient is living under at home.
Manager Valadez.
And I don't know if that's even appropriate for this.
Do it.
Interactions and.
Yeah, so within the electronic health record system, we can actually see, is the medicine prescribed internally? Is it prescribed externally? There is a process called med reconciliation that every provider and MA and nurse has to do. And if there are contraindications or risks,
Right.
I think those have to be weighed and accepted. Or the medication, is not utilized. And so I think if there is a need to do a handoff because there was an external provider that was prescribing a medicine and now there's a request, I think there's no way of automatically knowing that other than the care
Communicating.
team-patient relationship where you see the end potential date of the medicine. And there are some medicines that if there is, let's say there's a psychiatrist that is writing a medicine that is within her or his scope and it's atypical for me and I don't have expertise, it may be that I pick up the phone and I actually have to speak to that attending to find out, what, if, she or he would like this medicine refilled and under what criteria, because I may not have that expertise. So that's where I think the mission alignment really comes into play. Are we hiring providers that really care to do, justice by our patients? And it has to be communication, but it's not as cut and dry for that. So there is risk there. And then I'm gonna take a shot at the second one and then John can clean up the mess that I make. But we're focusing a lot on social determinants of health.
Right.
There's Find Help, there are resources internal to our electronic health record system, and I think of a lot of what we're gonna be presenting to you and speaking with you in the near future are some opportunities to bridge the gaps in the social determinants of health. And that comes, it's so multifaceted. So the infrastructure within the electronic health record system is going to allow us to send kind of bi-directional messages to some of the social services that we've never been able to work in collaboration with. I think we have also done studies and have a decent understanding of the challenges that our patients have. Now, not on an individual basis, I think that has to be shared by the patient. But pharmaceutical affordability is definitely one of the significant areas that I know that Central Health has focused over the years, if you look at co-pays. But this is where I think looking at the Pharmaceutics and Therapeutic Committee, like which meds should be added because of affordability concerns, if there is a medical need to add that med, and those are some of the discussions that happen. And I'll turn it over to Don.
Sure, and I'll just add a little to Dr. Schultz's answer. I think pharmacy is a great example of why Alan and I sit up here together. It's hard to separate the clinical aspects from the financial aspects, as you gave
known.
that great example. So some of the aspects of the pharmacy program are certainly more operational. One of those is setting the co-pays and setting the patient financial responsibility. That's not a part of the scope of the MEB. Those financial decisions are part of the MAP program guidelines. Now, it's certainly a consideration what drugs are on the formulary and, making those affordable and having affordable options available. But the actual co-pays associated with MAP and MAP Basic are not the purview of the MEB or the P&T committee. It's should we offer the drug and is it safe and under what circumstances? So, there are a lot of opportunities there on looking at co-pays, what we charge, when we charge them, when we waive them, if there are opportunities to have caps on co-pays. There's also a very robust patient assistance program for getting drugs donated, a lot of that in the primary care setting. That's another aspect of what we need to stand up as we start offering specialty services as well, because a lot of those drugs are through manufacturer donation programs. So we will have people on site going forward that can help our patients with those applications.
Thank you.
Yes, ma'am.
Other questions? Manager Jones?
Just a question in terms of your role, our role, and your interaction with, say, the Travis County Medical Society. Are there communications with regards to practices based upon the unique nature of the district and them? I'm just interested in that interplay a bit, just briefly, not for detail, but.
Thank you. Great question. We actually have a great relationship with Travis County Medical Society. I serve as one of, actually, Texas Medical Association through TCMS. I serve as one of their delegates. I think whether it is awards and nominations, whether it's the practice of medicine, a lot of our providers sit on various committees. Dr. Jonathan McClements, who's currently their president, we work in close collaboration, with him. And I think there is active discussion. So it's a great relationship and an active conversation.
And is there opportunity to inform the society about the unique population we serve and the interplay that they can help in terms of assessing that in some of your dialogue or stuff? I assume you would, but I just want for the record to understand that we are also informing them as well.
I think there's always an opportunity to do more. I can tell you that Jonathan McClements, his platform over which he's hoping to affect change is really diversity, under-resourced, and opportunistic populations. And so that is what he's hoping to focus on this year. That was his presidency platform.
Manager Jones, I'll just add, we've worked with the Medical Society for years with the Project Access program and also identifying providers that, want to serve our patient population outside of that program. And we've pursued contracts with individuals that were identified through the Medical Society as well. I think Dr. Shalsha also coordinates with the Medical Society and some of the professional associations in town for recruiting in our direct practice environment as well.
Seeing no other questions, I'm going to move on to the agenda items 1, 2, and 3. We're going to take them into closed session. Agenda item 1, again, I'll receive a report from the Medical Executive Board on governance, functions, compliance, quality, and future communications. Agenda item 2 is discuss and take appropriate action on Nursing Peer Review Committee and its related Nursing Incident Report Peer Review and Nursing Safe Harbor Peer Review Policies. Agenda item 3, discuss and registration with the National Practitioner Data Bank. It is August 23rd, 2023. It is now 3:42. We're going to go into executive session. Please forgive me. I announced that the committee is going into convene in closed session to discuss agenda items 1, 2, and 3 in accordance with Health and Safety Code Section 161-032B as defined by the Texas Occupational Code Section 151.002 under the Texas Governance Code 551-071, consultation with attorneys on agenda items 2 and 3. Please forgive me.
One also, please.
That'll also be for agenda item 1.
change the circumstance.
Initially I did. We're good to go? We're gonna come back into open session. Today is Wednesday, August 23rd, 2023. It is 4:22. We took an executive session, agenda item 1, 2, and 3. Agenda items 1 and 3 are informational items only. We'll bring agenda item back, 2, back into open session. Let me read it again. Discuss and take appropriate action on the nursing peer review committee and its related nursing incident report peer review and nursing safe harbor peer review policies. At this time, I'm gonna take a motion from Manager Martin.
I move that the medical committee recommend the board of managers approve the formation and implementation of a nursing peer review committee and approve the nursing incident report peer review and nursing safe harbor peer review policies as presented by staff.
I'll take a motion from Manager Musaitis for a second. So Manager Martin made the motion, seconded by Manager Musaitis. All in favor, say aye. Aye. Motion passes. Second? All, aye. Motion carries. We're
Today is August 23rd, 2023, and it is 4:32 PM. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. For public communication, I understand we do not have any signed up. Thank you. So we do not have any public communication today. Members, before we begin, I would like to reassure you all and the public that Central Health, our board and this committee strive for transparency regarding the annual budget and tax rate setting process. However, due to ongoing litigation, there may be certain budgetary items that we cannot discuss in open session, and we may need to have a closed session where some of these questions may be addressed. We're gonna be proceeding with our committee agenda. I just want to let you all know that we are gonna go out of order. We will be taking item 1, 2, 4 first, and then we'll take 3 and 6 together. Actually, yes, 1, 2, 4, and 5, then 3 and 6 will combine for a closed session. So at this moment, we're gonna proceed to our agenda. Agenda item 1, approve the minutes of the August 9th, 2023 Budget and Finance Committee meeting. Do I have a motion? Manager Valdez?
I move that the committee approve the minutes of the August 9th, 2023 Budget and Finance Committee meeting.
Thank you. Do I have a second? Second. So I have a motion by Manager Valdez and a second by Dr. Bell. All in favor?
Aye.
The motion moves. Thank you. Item number 2, receive and discuss a presentation on the proposed Central Health fiscal year 2024 budget and tax rate. For this item, Jeff Knodel, Kim Johnson, and Mike Giesling will be presenting. Thank you.
Yes, and members, as folks are coming to the table, I'd like to, first say that, we appreciate the questions that you've sent. We're cataloging those, and we'll, by virtue of these presentations, answer many of those, but we're also going to document when and where and how we answer them, and we'll put this on the message board so that way it's publicly available. And then, if we can go ahead and advance to the next slide. And just as a reminder for folks that might be tuning in for the first time and trying to understand Central Health as the Travis County Hospital District, we serve 1 in 9 Travis County residents, and we focus on individuals that are below 200% of federal poverty level. But just in FY22 alone, we served over 150,000 patients, and through Sendero, MAP, and MAP Basic covered over 120,000 individuals being served across over 220 provider locations around Travis County. And our patients are predominantly people of color, and we are linguistically diverse, and as far as gender identity, tend to be predominantly female. But we want to make sure that we talk about health equity, that we are operationalizing, and you will see this in the presentations today, what that means, and that is helping people live the healthiest life possible and working diligently to fill the gaps in our healthcare system so that there is a standard of care that is available for low income that is the best that it can possibly be. And one standard of care, not a bifurcated system, not one for low income and then another for everybody else. That is absolutely not going to happen. So with that, let's go to the next slide, please. I'll turn it over to Kim.
Hello. So we wanted to just walk through a few of the changes and adjustments that we made from when we presented our initial budget to you all on the 9th of August. First of all, you'll notice that there is a slight adjustment in the tax rate, and that is just based on the final rates after the truth in taxation calculation process. So this is the official calculation. So there was that minor adjustment. Also, we adjusted the FY '23 lease revenue. We had initially had 12.3 million, but in fact, that is estimated to be closer to 13.1 million. Where you'll see that impact is actually in the reserve amount, because the revenue was higher than we had initially included. That made the year-end reserve balance slightly higher, which caused our overall reserves for FY '24 to be higher. You'll also see in salaries and benefits, a slight change. That's just due to changes in the employee allocations for our human resources department. That's an enterprise department. And in working with the enterprise partners, we made some adjustments to how those employees are allocated. That also accounts for the change in the FTE count, because we shifted more of a percentage of those employees being allocated to central health. And then, of course, we had an adjustment to the emergency reserve transfer based on the other adjustments that we made, as well as some minor adjustments in direct services and clinical support costs. Next slide. So this is the detail, attachment B of the budget here, and I have put asterisks next to the numbers that changed from what we had initially presented on the 9th. The increases throughout the direct services categories are just increases in salary and benefits due to grading adjustments of those positions. And then, next slide, please. The changes in the first two asterisks, the salaries and benefits and the real estate and campus redevelopment, is just because we inadvertently had the salaries and benefits for the real estate staff rolled into the initial number. So we moved them out of the real estate and campus redevelopment category and put the salary and benefits with the rest of the salary and benefits. There's also an outreach and branding initiative that was added, that was part of a approved new initiative. And then we adjusted some expense estimates in some of the other expense categories. Next slide. And then the changes on this slide are primarily related to adjusting some of those allocations from the HR enterprise employees, as well as some of the other expenses within that department. We adjusted the allocation of those expenses as well. Next slide. And then we wanted to quickly touch on our capital budget. This is just an overview of all of the projects that have been approved. You'll note we're not adding any funds this year, and we're not adding any new projects. So this is just a carry forward of the projects that have currently been approved. Next slide. And I'll hand it over to Jeff.
Thanks, Kim. So this next slide is a depiction of our financial forecast reserve slide. Just to reiterate, and we'll reinforce that in the next slide, is that in the upcoming years, based on the assumptions that we take in our long-range planning, we anticipate having what's called a spending gap. So in other words, our uses are greater than our sources or revenues that come in. But this is one of the reasons why we've built reserves up, in order to accommodate that over a period of time. And then secondly, you see our reserve levels, the blue line, as over this 7-year period. Due to that to the gap, the decline over that period of those reserves, but to the point where we're still ending up during this period within our targeted range that we were trying to achieve during that period. Next slide is, the top slide is really just the same slide as you just saw. In addition to that, there's a summary synopsis of our healthcare equity implementation plan that was recently approved by the board. It's a significant investment that the board has approved over the 7-year period. What you see on the chart are incremental increases year over year. Again, it's a significant investment over 7 years. It's about a little over $680 million. So certainly that was one of the, certainly the wisdom of the board approving building reserves so that a healthcare plan of that significance could be implemented to close the gaps that were identified in the assessment and analysis. In addition to the healthcare equity implementation plan, there still are a number of risks that we hold as an entity, and some of the primary reasons why we hold reserves. You see them listed in the, I see that's a purple or blue box. But you see financial, and these are either standard risk or to some degree some uniqueness that we hold as a healthcare entity, but certainly financial risk can include things like inflation and supply chain issues. We've seen that over the past few years, some significant increases. Certainly a lot of operational risk. I think there was a discussion that we had last meeting related to some of the implementation risk and the levels of services that may need to be right-sized. Certainly, we always hold a risk related to regulatory or legal or legislative risk. And, certainly some of that risk is related to some of the funding structures and abrupt changes to some of the supplemental funding structures that exist, throughout the state or the federal level. And then certainly last but not least is workforce risk as we embark in the implementation of the plan, and especially as we embark in the direct service lines, just the ability to stand up those lines and to recruit in sufficiency the clinical leaders, the clinical providers that we need in order to provide those services. Next slide. So this is a 5-year look. It's a little bit different look than the standard look that you see in some that you've seen in the past from us. So this is simply taking a 5-year look of a homestead that begins in 2020, and we know that with values increasing double digits year over year, that it's reasonable to expect, and we see this every year where the homestead values increase at least 10%, and which is the cap year to year. And so this is simply a 5-year look of a 10% year over year increase beginning in 2020 of a $350,000 homestead property, and you see the 20% homestead exemption that the board and the Commissioners Court have approved year over year during that period, and then the actual tax rate that existed for both that year, and then the proposed rate that I think we had in our earlier presentation. But what you see looking at the graph is the actual payment has increased as we've raised our new revenue, no new revenue rate. But there are times where growth is so significant in other non-homestead areas that even though our tax rate or the no new revenue rate may increase, the tax rate actually decreases, and actually the tax payment has decreased also. You see that between 2022 and 2023. I've highlighted just really the last 3 years just to note that the kind of the average increase over those 3 years is about 4.5% annually. So I'm going to hand it over to Cynthia to walk through. We had a discussion at the last meeting of some of the tangible, coming back and talking about some of the tangible enhancements that we're making to our healthcare system to try to address the gaps. And so we've done this presentation up to try to address some of those questions. So I'm going to hand it off to Cynthia and have her walk through the next few slides.
Sounds good. I don't know if this is on or if I need to pull it closer. Are we good?
Yeah, just turn it towards you. There you go.
Haven't seen anybody touch it.
Perfect.
Okay. Good afternoon, managers. I'll kick us off with the direct healthcare services, starting off with Rosewood Zaragoza and the 6 specialty service lines that we're looking to stand up come early FY24. As a reminder, this is a clinic where we will be having the 6 specialties, including cardiology, pulmonology, GI services, neuro, nephro, and podiatry services. Ultimately, this clinic will be seeing, once fully ramped up, 30 to 35,000 patient encounters annually. On top of that, we will continue to build complementary programs to support several of the service lines that we will be having in Rosewood Zaragoza. A couple to name are our CKD program as well as our renal disease programs. And this is really to make available services for the more complex patients that we'll be taking care of in Rosewood Zaragoza. On top of the work that we're doing in the specialty clinic space, we continue to really launch from the transition of care work that you heard a little bit about earlier this year. As a reminder, the transitions of care space really lies within the hospital EDs as well as the inpatient settings, with the goal of really helping with warm handoffs for patients that are being discharged from the hospital into the multiple settings, including skilled nursing facilities, home settings, primary care settings, and others. And we're doing that by expanding some of the existing teams that we've started to build over this last year. That includes roles such as social worker roles, community health worker roles, as well as RN roles over this next coming year. We will also be continuing to expand our medical respite teams to support several of the contracted services that we currently have available this year. And really what that looks like is really expanding some of the RN support as well as medical assistant and CHW support for the programs so that we can make or have a presence in additional sites. And I'll talk a little bit more about some of the expansion we're doing in our network slide. Outside of that, we'll continue to really work on our launch and continued launch of our electronic health record. As you can imagine, as part of standing up a clinic infrastructure, having an electronic health record available for the providers as well as for the patients that we serve is a pretty large undertaking. We have had a couple of soft launches as well as go lives for some of the existing teams that we have been able to get off the ground this year, and we'll continue to work to improve that as well as make services such as MyChart available over the next coming year. This is an important one, as we get services such as RZ off the ground, as well as transitions of care and many of the others, ensuring that we have translation services as well as transportation services and other services available that help really remove some of the barriers that our patients experience is really crucial. A lot of time and effort have been going around into what we've called kind of the care model design in order to ensure that we're really thinking through the multiple scenarios from the time the patient comes in or the member comes in as a MAP eligible member, all the way through discharge, and ensuring that we're kind of thinking through some of those critical aspects in an experience for the patients. Next slide. Talking a little bit about the healthcare operations and support, definitely want to lean in on some of just the existing infrastructure that we continue to leverage and expand upon. Hornsby Bend and Del Valle are centers that we're looking to launch that include expansions in areas that we continue to identify a need in, including primary care as well as dental. We will be expanding eligibility and enrollment teams to add additional team members, as well as to continue implementing and expanding upon our virtual enrollment efforts. And that's really to be able to reach individuals experiencing homelessness, as well as to be able to insert resources at new sites such as Hornsby Bend and Rosewood Zaragoza. We will also be continuing to establish the Central Health Navigation Center with several staff members. And the role of the Navigation Center, just to take a step back, is really to ensure that the patient experience once they enter our doors as a member all the way through, kind of helping navigate them through the system that we are creating and continue to improve, is really a good experience. This is a navigation center that we really look to stand up services such as patient experience. This is where the transportation will be housed. This is also where we continue to update eligibility and enrollment for individuals. And we'll be doing some new functions such as scheduling of appointments and hopefully future pharmacy virtual type visits. Outside of that, we continue to build upon the technology infrastructure and really being able to grow the data and analytics and reporting systems. And this is really to help track patient outcomes, trends in health conditions, as well as improve overall care conditions, care coordination, for the patient. This is also just ensuring that, from an organization that is growing and expanding into new areas, making sure that we've got the securities in place and that we are continuing to grow our IT infrastructure to support some of the substantial work that we are working through. And then we continue the Sendero Affordable Care Act subsidy programs, which are serving more than 4,100 members. That is about 2,000 more people than we were able to serve last year. Next slide. All right. So purchased healthcare services, we talk a lot about the direct practice work that we're starting to invest in, but this is still an area that we're very much expanding in the several areas that we have work in. So for example, community care, we continue to work with them on their street medicine and mobile clinic team expansions over this next coming year. We also look to work with the county on a diversion pilot to try and make a service available or a center available for individuals experiencing mental health crisis. Rather than having them go into settings such as a jail setting, this is an area where they might be able to have another opportunity to receive support services necessary. And then in the medical respite space, this is an area that we continue to work to expand with our existing partnerships, really trying to lay the land and understand kind of the work that's happening, the services that we can provide, as well as work towards expansion to additional beds at the existing contracted sites. And we try and take away a lot of lessons learned as we work towards our future Cameron site so that we can start creating some of the infrastructure that will be required for that in the next coming years. And then primary care, substance use disorder, apologies. So for substance use disorders and addiction services, this next coming year, we look to potentially expand in the treatment bed space. We are also looking to expand with our existing methadone partners, CMS and Dr. Oshbach, to expand to include MAP basic patients, to include MAP basic patients, as well as to continue expanding on the MAP front as necessary. And then lastly, in the primary care and specialty care expansion of access, we continue to work with our primary care FQHC partners to to work with, how we can support them in expanding to after-hour care, as well as evening and weekend access for our patients, as well as additional specialty expansion in areas such as ENT, audiology, women's health, tubal ligations, and many more. So specialty care continues to grow as we are able to. Next slide. All right, and I think, Jeff, you take this.
Yeah, I'll take this one. So, the next slide, is related to our administration program, and there are increases in administration. And as you can imagine, as we build out both, the direct practice and build out the framework of delivering all those services, that there needs to be, appropriate support for those, functions. So a lot of the increase is related to, oh, thank you. Sorry, I'm trying to talk loud enough, but, a lot of those, costs are related to human resources, in particular around recruiting, the providers, the clinical staff that we need, as it relates to providing those services. And we've talked about, at our last meeting, some of the risk where if we have significant shortages that, or vacancies, that they could impede our ability to deliver the services at the level that we expect to deliver on. So that's definitely a critical area that some enhancements have been made. In addition to that, with the direct practice of medicine comes, Medicaid, provider numbers, a lot of compliance issues, and so certainly trying to enhance our compliance departments and the functionality of the compliance areas necessary. And then last but not least, on the financial side, just the finance, procurement, again, as we expand services, but other functional areas that we have never had, for example, something called revenue cycle. So the ability to manage some of the co-pays as we, we're now responsible for those because we're running our own clinics. And so we're doing a lot of the functions that when we contract for services previously that have been done on our behalf. Next slide. So this slide is both a history and a projection of both primary care visits and unduplicated patients. And it goes back to 2016, and we've projected out for the next couple of years. And I think the takeaway on this slide is we're providing more services and seeing more patients than we've ever seen before, and that trend will continue over the next few years related to the time frame of this graph. Next slide, just to go through the calendar. Again, we've checked a few of the dates off. And then we also had a community conversation in Pflugerville last night that we haven't checked off yet, but rest assured it occurred, and it was a very, very successful conversation. We have one more conversation on the 28th at Southeast Health and Wellness Center. We're here today on the 23rd. We're scheduled to go to the Travis County Commissioners Court on the 24th, which is tomorrow, a work session. We are going to have an agenda item at the board meeting to set our public hearing, but we're proposing that public hearing would happen on August 30th. So we'll be coming back to you at that meeting to request action related to setting that date. And then the 6th and the 7th, we're at Central Health again, related to our budget. And the 7th would be the Commissioners Court, and then returning back to the Commissioners Court on the 19th of September for a final consideration of both our budget and our tax rate. So thank you very much for the opportunity to present our proposed fiscal year 2024 budget. There's a lot of really exciting things that are happening here, and turn it back over to the chair.
Well, thank you so much. I really appreciate all the efforts that took into this. It's, people may not realize, understand that it's a year-long process, not a couple weeks that we've worked on this project, on this budget. So I want to, first of all, extend my gratitude and appreciation to every single person involved with this budget. Thank you for all your hard work, and I apologize for your sleepless nights. And with that, I also, sorry Cynthia for not recognizing you, I apologize. Welcome. And a couple things before I open it to the board. Now, for slide item number 20, I know for our capital projects, we have not allocated any funding. And those are previous funds that we've allocated. Can you, for the next meeting, at least give us a tracking where we're at within this budget? So we want to know if we've exhausted where we are in terms of that expenditure.
Sorry, which expenditure?
For slide 20, the major capital projects budget?
Oh, yeah, okay. Sure, and we report those on financials, the budget and then the spend, where we're at, both inception to date and fiscal year to date. But yes,
Yeah,
we can.
Given
I
that
think
it's in,
there's
within
I think
the,
there's yeah.
because it's part of our budget, just in terms of transparency where we're at and how much
Sure.
we've expended. Now, thank you, Cynthia, for those last presentations. I think it is kind of more of a narrative of what this money is. Yes, we've increased our budget to a certain amount, but where that increase is going. So I think that that is helpful, and hopefully it is well communicated to our community and how we're spending their funds. So those were my comments. And also, before I open it, I want to encourage our community to participate on August 28th at our final community conversation, but to also know that we do have a public hearing on the 30th. And I thought we had 2 public hearings, don't we? Only have 1?
No, just one.
Okay. To encourage everyone to voice their approval or concerns, however they would like. Now, board members, do you have any questions? No questions? Manager Jones?
Just one quick question. The Hancock facility that we're developing is going to play a critical role in terms of service housing. Does that include the navigation center ultimately?
No, the Navigation Center, I think, is set to sit at Cameron Road.
Cameron, okay then.
Correct.
But for those facilities at Cameron and one at Hancock, what do we anticipate doing over the next year or 2 before they are open? How are we going to house folks? Where are they going to be operating out of?
So I will take a stab at that. To make sure I understand your question, you're looking to understand where we will be placing individuals? Yeah, so we have space at the airport building that we've been leveraging for even some of the staff that we're bringing on board for RZ, given that it's not open yet. And so I think it's our understanding that we will have that staff move into East, then into RZ. And then as we're kind of coordinating that and up and operationalize, the staff that we would be hiring for the Hancock space could potentially sit at airport and could sit at airport as part of some of the overflow space that we have. Does that make sense? Sorry, the Buttercrust Factory.
Yes, it's the old Buttercrust Bakery.
Sorry.
It's the old Buttercrust Bakery on Airport. Yes, yeah, we had to move.
Thank you, Manager Jones. So I see no further questions. Yes, Manager Valdez?
Just some quick things. On the implementation, Riss, I was unable to make the August 9th meeting. Is it possible for someone to give me that information, or just send it to me? If that's okay.
What
It
implementation?
said the implementation risks, Jeff, you
Yeah,
outlined.
I think it was more of a discussion,
And
but sure.
Or I can give you a call and we can have a conversation
That-
about that.
I
That
think we were
meeting-
trying to capture some of that in our, we have kind of a we have kind of a running list of questions, and so we were gonna, so we had the
Yes.
conversation, and we're gonna go back and kind of answer that, more through a process.
Okay?
Can we, is that okay if we just?
Manager
Yeah,
Valdez?
if, I'll give y'all a call if we can, or if Mike or Brianna can set up a meeting, so I can come back in sometime between here and the next meeting.
Are you referring to our,
I'm sorry. Here.
Manager Valdez, are you referring to our last budget and finance meeting?
I'm referring to the meeting that occurred on August the 9th, that I was not present at.
Was that
And
budget and
since
finance?
Jeff alluded to some implementation risks
Yeah, we had a-
regarding
we
the
had a-
budget.
Sorry, we had a conversation where I think that was kind of one of
And
the,
that was an open session, correct?
yes.
So the
Yes.
recordings are there as well for you to actually watch, and
I can
think-
watch it, but I'd still
So-
like the opportunity to have
I
a
understand,
discussion.
but I will also encourage you to watch it and then
Yes.
afterwards to present your questions. I think it'll be helpful for you to know the
No,
context.
I understand that, but I'm going to meet with you
Okay.
about that. And I'm not through. With respect to the eligibility and the criteria on eligibility for MAP and MAP Basic, are we, as a board, ever going to look at changing some of that criteria so that more people can enroll in MAP? Because wanted it to go from 6 months to a year. And two, we wanted to look at the financial criteria to see whether or not we could expand the number of MAP eligible as opposed to from what it is, the criteria that it exists right now.
I think that the board can look at that at any time as part of the budget process or even outside of the budget process. And so really, that's the prerogative and/or the will of the board. Now, as you know, and we've discussed multiple times that the eligibility, so MAP Basic is 12 months, but MAP is 6 months.
That's right.
That the MAP issue is also related to the
Litigation.
litigation that we have at hand, and so we can have those conversations in the proper setting.
That's right.
But I will also point out that the eligibility and enrollment teams, there is a process by which it, to reach out to individuals to make sure that coverage does not lapse. And then, of course, with the encounters that individuals have, with our providers, be it at community care or any of our other primary care, points of encounter, if you will, to ensure that people understand, please keep your MAP coverage current. And so there's ways to address that 6-month period even before, getting to 12 months, which is the ultimate goal, which this board has stated and made very
That's
clear
right.
publicly that
That's
that's
right.
the ultimate goal. So again, I know those are just kind of a smattering of bits and pieces of responsive information, but at the end of the day, that is certainly the prerogative of the board to look at that. And then noting that, what you saw on the one graph where the primary care visits and patient counts will go up, we have, in utilizing reserves and all the care programs that Cynthia would referenced are designed to do just that, is to provide more care to more people.
And with respect to the sites, I know that you were talking about a Central Health Navigation Center. I know that historically, it's been, I think, a good practice to have at least some navigators or patient navigators at the clinic sites. There's a lot of downtime while they're sitting there waiting for their appointments, where that time could be utilized by someone who could be working with them to make sure that this is a productive and positive experience for them. Not just everybody housed in one center, but rather on the sites where the patients are, and that way you increase the patient confidence level and exposure to the employee, so that hopefully their satisfaction will be improved, but not only that their access to care you know, maybe there's some things that they won't always talk to the doctor about in their 5 minutes before a doctor. But they can talk to a navigator who should be well-versed in how to extract that information from the patient if there are needs that have not been addressed by anyone. And so,
Can I respond to that?
yes, please.
Just a little bit of additional detail that I can share with you is that we do have resources planned to be on site for that exact reason, and we're kind of creating them as part of the care model, the care team, including social workers, RN navigators, et cetera, to be
Promotoras.
available.
And I appreciate that, thank you. And also the Sendero 4100, you said that's an increase of 2,000? That will be an increase of 2,000?
It will have been an increase of 2,000.
2,000 for this, this calendar year?
Correct.
Of '23? And,
FY '23, sorry.
I'm sorry?
FY '23.
Yes, which is a calendar year for Sendero.
Yeah, we'll have a little more discussion about that, but it's for '24, so it'd be an increase of about
For 24.
2,000 for '24.
Starting in January.
Yep, calendar year '24. Remember, they're on the calendar.
No,
year.
I understand, I know, I used to be a
For us,
navigator.
but For us,
Hello.
it's fiscal year also, yes.
And I think the substance use disorders, you did say that that was, so those services are being provided for the MAP and MAP Basic population? Great.
We're working to make the methadone services available, I'm sorry. We're working on expanding our methadone services to MAP Basic over this next coming year.
And where will that center be housed? I know that there has been a meth center right here on Second Street forever.
So that's actually in partnership with CMS, and I am.
Integral Care?
Integral Care partnership as well, but I am blanking on CMS's
Community Medical Services
and Dr. Oshbach,
Oshbach.
correct, yeah. And they have north locations as well as Dr. Oshbach is a south located provider.
Okay, and just for clarification purposes, I had, I guess, in the last meeting that I did attend via Zoom, I asked whether or not the balance was going to be, this budget was going to be a balanced budget. Is it a balanced budget or is it not a balanced budget that's being presented this year?
Yeah, so defining, sorry, make enhancements and, so if you're defining balance as structurally balanced, which would mean revenues are
Matches.
at least as great as expenses. No, expenses are greater than revenues, and we're closing the gap by the use of reserves. And that's what we're showing over the next several years. Again, it was, you know, part of the rationale of we're gonna build reserves up to address, you know, gaps in our healthcare system. And then when we have a plan in place to implement, that we'd have the resources to do that.
So then for the 406 million that will be there in reserves for 2024, is there going to be an asterisk that will show the public or show us how that money, what exactly, what part of that monies will be used to balance the budget for what projects? Or in what areas?
Well, generally speaking, the overall budget, you don't assign reserves to discrete line items or discrete
I know.
projects. It's just a kind of an aggregate. I
And the
think-
reason, I'm sorry, Jeff, the reason I'm asking that is because in listening to the Integral Care budget presentation yesterday, you know, apparently David had Integral Care go to great lengths to make sure that they would present a balanced budget. And he said that in the presentation. And so for us at Central Health, I want the public and us to be clear as to exactly how our budget will be balanced by using those additional reserves. And I think that would maybe best be shown by an asterisk at the bottom when we talk about the reserves. I'm just asking if that's a possibility or not.
So,
I'd like for Jeff to answer, please.
Yeah, let me take a quick stab at that. So first of all, I think on slide, or page 21, I think you can see just the overall reserve picture over the 7 years.
Yes.
Secondly, the board has established a contingency. A contingency
Contingency fund,
reserve
yeah.
is exactly what you're talking about. It's
Right.
a reserve that's set aside for temporary structural gaps. And so we've built our contingency reserve up in order to sustain multi-year gaps, and that's what we're doing. If you look at this chart, the use of those reserves are addressing that structural gap, but you see the structural gap starts to close as you get towards the, more in the outer years. So that's exactly what a contingency reserve is for.
Okay,
So I
so
don't know if that answers your question, but that's really, we can,
I'm getting a better understanding of it,
Yeah,
but what I
and-
wanted to ask you is, so it says 33 million here in 2024? So that 33 million in 2024 is going to be that part of the reserves that will be included to ensure that our
point me
sources
to
and
can you
our
point me to
uses are,
What are you referring to?
oh, yeah, yes, yes.
I
I'm
just want to
sorry.
make sure that I'm understanding that that is in fact the case.
Yes.
And that, thank
Yes,
you.
Reserves are.
I'm glad you understand
Yes.
what I'm asking.
Yeah, just point me to the right slide. and I'll
Yeah,
tell you.
22, the same one you wanted me to look at.
Yep.
Okay.
Yes.
And so 2025 then, whatever the budget is going to be in 2025, there is a possible what is that, 50?
Well, this is again, this is the incremental.
Although we can't look
the-
at it for
yeah,
that year.
Let me just clarify, this bottom graph is a graph of incremental costs of the healthcare equity implementation plan. And so it's really just showing the major investment. Obviously it's significant over the time period that we're showing. And so it's really just showing it's certainly one of the cost drivers that's occurring over the next several years that we're using reserves to help fund that over this 7-year period.
I understand the implementation of the equity plan and the strategies that we're going to do to accomplish that. But what I was specifically asking about is whether or not there is going to be a way for the public to know how much money and to what is it going, since we will be presenting an unbalanced budget.
Well,
I'm asking,
Well,
I understand, can I just, sorry.
Sure.
I just want to make it very clear, our budget is within balance, so the definition of balance could be interchangeable, given our budget is unique to other entities. I just want to make that very clear, so just don't want it to be miscued that our budget is it's not balanced, which
Yeah, we're using contingency
We're using
reserves.
contingency.
I understand that, but that's why I'm asking
Sure.
specifically how much money of the contingency reserve we'll be using and for what projects, so that the public will know how that money, the taxpayer dollar, will be spent.
Okay.
Because it isn't even clear to me.
Well,
So-
so I'm just gonna leave it with this, and then we can figure out.
We can have
if we
another
need to.
conversation.
But if you look at slide, or attachment.
Well, that upcoming conversation, Jeff, if you can explain it to me.
No,
You know.
actually, this is important, and so if you'll let
yeah.
Jeff work
Yeah.
through the
Please.
Schedule A and Schedule B, it's spelled out very clearly and for everybody to see. And so this is, if you'll allow us
Right.
that much. Thank
Yeah,
you.
Yes, please.
Thank you, and I'll make it really brief. So what you see on Schedule A, which is slide 16, or page 16, sorry, is at the very bottom. So you see our sources and uses for 23 and 24, and then at the bottom, you see our two primary reserves. You see the balances of our contingency reserve and our emergency reserve. And so over time, over the 7-year period, you'll be able to see the tracking of those balances. But I'm just gonna, we don't have discrete funding sources for every line item or every project. So really, we're using
By
our.
design.
By design, we're using our contingency, well, a lot, almost every governmental entity is that way. No one really budgets for every dollar that comes in, here's exactly where we're spending it. I'm not aware of any, unless they just have a single source of revenue, and we don't. But you'll see in attachment A, you'll see the reserve balances of both the contingency, which, again, we're saying the use of that is for one time or years where our expenses are greater than our revenues. Our emergency reserve is a little bit different. That's what's called a hard reserve. So that's a reserve that's set by policy. And if we were ever to use emergency reserve funds, we'd have to come to the board to request withdrawal, and we would also need to have a plan to replenish that fund.
That's why we're not using them. Is that correct?
Well, we don't have the need to use them.
That's right, because we have all that
because
money built up
you
in the
as
contingency.
board have set aside enough in the contingency reserve.
That's right,
So,
because we have that build up, yes.
so that's really more of a emergency nature type of use. So I'll leave it at that.
Well, thank you, Jeff.
I appreciate it. Thank you very much, and thank you, Mike.
Thank you. Thank you all, appreciate you. Moving on to item number 4. Receive updates on the preliminary July 2023 financial statements, including capital projects for Central Health and Community Care Collaborative. Mr. Jeff Canodal has a short presentation.
Yes. Extremely short. We've included in your packet financial statements, July financial statements for both Central Health and the Community Care Collaborative. If you have any questions, feel free to reach out. I will point out 2 highlights in July that have happened. Number 1, we've accrued for the UT affiliation payment. That payment actually is due on no later than August 15th, and we've made that payment. In the July financial statements, you'll see an accrual for it. And remember, the Community Care Collaborative was partially funding that. So the actual amount that was paid out of the Community Care Collaborative was $12,570,000. And then Central Health, as the guarantor, made up the difference, which was $22,430,000. So that's the first thing. The second thing that I'll point out is on the Community Care Collaborative financial statements, HHSC's notified us that all the audit periods of all the Deseret projects have been completed. If you recollect, we have set aside reserves in the event that there were any recoupments or any errors. There were none, so we've taken the reserves, excuse me, and this is an accounting term, but we've taken the reserves out of the reserves and recognized that revenue. And so you'll see that on the sources and uses. So thank you very much.
Thank you so much, appreciate you. Do you have a question?
Yeah, with respect to that, did we ever find out about the letter that CMS had sent out? Did we take care of that and there was nothing, no problems? I thought that there had been a letter sent to us stating that there were some expenses that were not allowed.
I think that's.
And that was,
probably
may have
something
been
we
within the last year or year and a half, 2?
Legal?
I think that's something.
Sorry,
that-
Manager Valdez, could you, we're not tracking, I mean, we understand the words, but is there a specific letter that you're referencing?
No, I just wanted to make sure that we
I-
took, that Central Health
Excuse
was
me,
not found to be,
I think
I
that
think-
that's a.
to have a
legal-
problem.
Mike, let me just jump in. I think
Please,
that's a
yeah.
legal issue
Yeah,
that we
that's
should take up in closed session.
Okay.
If need be.
So are we going to take it up today, or is that a question I can have answered offline? Okay, then I'll have it. Thank you, David.
Okay, thank you all. Any further questions? No, I see none. Thank you, Jeff, appreciate you. Now, item 5, receive and discuss the quarterly financial and operational reports for community care health centers and Sendera health plans. Is Jason here? He's on? Oh, okay, perfect. So we'll first take on community care. So Jason Fournier and Tara Trower will be presenting. Welcome.
Good evening, managers. Can you hear me okay? Yes, can you just make your voice a little bit louder?
I will do my very best. I apologize. I'm en route back to Austin in an airport right now, so I'll speak as loud as I can. If it fades, please just let me know. And Tara, unfortunately, is going to be remote as well. She's under the weather, but is still feeling up to being able to participate. So really appreciate the opportunity this evening to provide Community Care's quarterly report to the Budget and Finance Committee of Central Health. And first and foremost, as always, I want to express our sincere gratitude to you as the Board of Managers and the staff at Central Health for your guidance and leadership as we continue to collectively advance health equity within the community. I'm going to spend the first couple of minutes just walking through some slides. We know that the written report was provided to you guys within your packet. Happy to answer any questions, not only on the slides when appropriate, but also as well as related to the information provided in your packet. So if we can
Thank you.
advance.
So I will entertain the questions after you present. And
Sounds good.
okay, perfect. Thank you.
Yep. So just as a quick update, all of our work is focused on and related to our Board of Directors strategic plan. As you may recall, that our patient majority board is co-applicant with Central Health as it relates to the health center program. And at the focus is equity. One of the things relative to our ability to drive equity is tied directly to workforce. I heard earlier this evening, multiple inclusive, and Cynthia and Jeff both speak to workforce, and that's critically important. As we get into tonight's report, you'll see that our trends are up because we've been able to increase our ability to go ahead and recruit, retain individuals. But that's something that's going to be critically important to not just us, but any healthcare provider, specifically within Austin, but across the state and across the country moving forward. So we're going to touch on several of the strategic priorities in alignment with that. So if we can advance to the next slide. So one of the things that we've been working on since 2018 in collaboration and partnership with Central Health is a realignment of our overall health center assets. And that includes looking at the physical infrastructures. One of our statements within our vision statement is providing the right care at the right time in the right place. Well, the right place is, whenever feasible, proximal to where folks live and exist and work, correct? And so when we take a look at that, one of the things we've deliberately been working towards with your support has been looking at how do we go ahead and realign our clinical assets to better reflect the changing dynamics within the community and demographic shifts that unfortunately have adversely impacted our historical populations. So within the quarter, if we can advance to the next slide, within this last quarter, we were very pleased to go ahead and open up our new Pflugerville Health Center. That health center is 5 times the size of the long-standing health center in Pflugerville that had been located within the Travis County Services Building in Pflugerville. The new facility not only provides and continues to provide family medicine services as it always has, but expands the services to go ahead and include direct pediatric services and dedicated services, women's health services inclusive of obstetrics. And additionally, for the first time up in Pflugerville, we've added both pediatric and adult dental services. So it's a significant expansion of the services of note and reflective of the realignment strategy that's been in place since 2018, recognizing changing dynamics in East Austin with our partners at the University of Texas at Austin, Dell Medical School, and Ascension Seton. The pediatric residency program was shifted from East Austin up to Pflugerville. And that's a reflection, again, of the shifting demographics within East Austin and the pediatric population and higher concentration further north. Of note, we have expanded evening hours as well as Saturday hours that are planned for the Pflugerville site and have already been implemented. So what you can see on the slide is the grand opening here with Commissioner Trevelyan, had strong support through him and in partnership with him and other representatives from the Pflugerville community, and really looking forward to the expansion of services that are happening there in conjunction with what Central Health is helping us with and supporting. If we can advance to the next slide. So quick update relative to activities. So last year in 2022, you may already be aware that we served 129,005 unique patients. That was the most we've ever served in a calendar year. As you may recall, these statistics are reported up through the Health Resources Service Administration as part of the Health Center program. What we are noting is that over the 9-month period for fiscal year beginning October and the 9 months ending in June, so the 3 quarters that we're reporting on, we've actually served over 113,000 patients. That's up about 5,000 patients comparative to the same period last year. And so we're expecting to surpass in the calendar year over 135,000 patients. A lot of that's dependent, again, as it relates to workforce and what's going on. So some positive trends quarter over quarter. In the third quarter, we saw almost 66,000 unique individuals compared to about 63.5 in quarter 2 and a little less than 63,000 in quarter 1. So we're seeing that directly as it relates to an increase overall. We also similarly saw an increase as it relates to what we refer to as countable visits or encounters. Those are visits that happen face to face, either virtually or in person, but the vast majority of them are in person, with a billable primary care provider, dentist, dental hygienist, psychiatrist, or specialist. So someone who's a billable licensed provider with that definition, also defined by the federal government underneath the Health Center program. What's also very important to know during this quarter and going back to the beginning of the fiscal year is that we've hired more clinicians than we've lost, and significantly more. And coupled to that is the fact that we've also been successful in hiring more clinical support staff versus losing support staff. So there's always this natural transition of folks in and out of community care. We're almost 1,200 employees strong currently. And so we see this natural fluctuation that happens. So we are seeing a persistence of the favorable hiring trends of late, which bode well for the upcoming fiscal year start, as well as the last quarter. Some statistics on the right-hand side that you guys can see that I think is notable, as Mike indicated in his introduction earlier, 52% of Central Health covered patients and the 152,000 or so served in 2022 were best served in language other than English. We're a little bit higher than that within the patient populations we serve at community care. It's sitting at almost 61% overall. And this is relative to folks who are actually reporting to us. So the asterisks that you see here, a lot of this is dependent on the individual patients reporting to us. Some choose not to. Sometimes we don't always capture the information, although we endeavor to do so and do it at a much higher rate than almost any other healthcare provider in the area. And when we take a look at that aligned with the Central Health mission, 98% of the patients served had incomes below 200% of federal poverty levels, and 82% were Travis County residents. You can see that 41% of the 113,033 individuals were uninsured Travis County residents, with approximately 35, there should be a percent there, apologies, 35% MAP or MAP basic covered. Advance to the next slide, please. So some of the other things that were accomplished within the third quarter include a partnership with the Austin Public Health Department, and at the request of Dr. Walks was us standing up an Mpox vaccine weekend. And you can see the numbers of vaccines that occurred over the course of 2 days with support from our infectious disease and leader as it relates to Dr. Stefanovich, as well as Dr. Yagoda, who's our chief medical officer. And then we continued our efforts relative to COVID-19 vaccination efforts. That's something we have in conjunction and contracted with the Ascension Medical Response Unit to help with that. And for your awareness, we did decide in June to go ahead and pause those clinics, mindful that COVID wasn't fore of mind, but those clinics are ramping up into September and will continue through the end of December as we're getting ready for another round of COVID-19 spread within the community, knowing that the best and most effective way for us to go ahead and address and mitigate the impacts of COVID-19 is to go ahead and vaccinate the community.
Hey, Jason,
advancing.
I'm going to interrupt for just a second. I got a correction from my team on the number of vaccinated individuals for the quarter. It was actually over 300.
Thank you so much for that, Tara. So we'll make sure that that gets updated and submitted to you guys so you have a record of that. Advance to the next slide, please. So one of the things that I think is critically important for us and for you at Central Health, the Board of Managers to have awareness is how are things dynamically shifting as a result of the public health emergency, and specifically as a result of the end of the public health emergency and its impact on Medicaid beneficiaries and the required redetermination that's occurring. As you may be aware, starting in May, as of May 11th, the public health emergency had ended, and as a consequence, state agencies, Medicaid agencies inserted, including Texas, were able to go ahead and start the redetermination. There's multiple cohorts of patients or covered beneficiaries through Medicaid that are going to be rolling through the redetermination process. But first and foremost was going to be folks who were no longer eligible based on how they were able to continue their Medicaid benefits. A prime example of that is for someone who was a prenatal covered Medicaid recipient. If she had provided birth or delivered her baby back in 2021, as you may be aware, she had continuous enrollment with Medicaid that persisted as opposed to being dropped after 6 weeks postpartum, which is what typically would have happened prior to COVID. And so as of May 11th and moving forward, the state has been working to go ahead and do these redeterminations, again, noting that some cohorts were going to be automatically dropped. Another cohort, for example, that would be automatically dropped are pediatric patients who had aged out. So those who had turned 18 and over were no longer eligible unless there was some other reason for them to be eligible other than their age and income level. And so based on the state process, what we've observed in Q3 as a direct result of the redetermination process, and we're digging into this further, is the fact that we saw a precipitous drop in our Medicaid payer mix, 6.6%. And at the same time, we saw a rise in individuals covered as it related to both from an uninsured, not covered, so uninsured, and then individuals who were being covered now newly through the MAP Basic program. Of note, these individuals prior to COVID and the public health emergency were most likely being covered either through MAP Basic or were uninsured within the community. So it really does demonstrate the impact that the public health emergency had within the community. And so there's financial implications for us. There's also real implications for patients who had health care coverage and were able to access services as a Medicaid recipient, which now has been lost, unfortunately, within our community. For your awareness, we have been engaging through our Chief Operating Officer, our financial screeners, and others to go ahead and make sure that there's awareness around the redetermination. Foremost is making sure that they're looking out for information regarding the redetermination. And one of the best things, candidly, that individuals can do is make sure that their address is currently up to date with the state, and they're looking for the yellow envelope, an 8x11 envelope that will be coming in the mail to them. So that education's occurred. We've also gone ahead and expanded our hours into the evening for financial screening, as well as on Saturdays to help mitigate this impact as much as possible. Next slide, please. And so from a financial year-to-date performance, we've generated excess revenue through the end of Q3. Much of that is being generated by one-time monies from prior year. What's important to note is that while we're to the good right now, for lack of a better description, much of that is dependent and occurring as a result of lower expenses, unfortunately, which is tied to services as well. And much of the savings that's happening are not intentional. They're relative to workforce. And so one of the reasons why we're starting to see an increase in the unduplicated patients served quarter over quarter, as well as the number of countable visits or encounters increasing quarter over quarter with the greatest for year to date in Q3, is a direct result of the workforce initiatives that are happening in recruiting and retention. And certainly we are benefiting from the enterprise HR functions led by the Chief Human Resources, Jeannie Bearden, and her team, as well as our VP for Human Resources at Community Care, Mr. Yomi Babi. One of the other things of note is that while we're experiencing on the adult side, we're experiencing when we look at that particular line overall, there's a substantial operating loss that occurs. And then we're buffering or able to buffer most of that through not only reimbursement that we secure through Central Health, but also as a result of increased pharmacy revenue, as well as pharmacy revenue wherein we generate some income that can be used for overall services. So when we take a look towards the end of the fiscal year, we're anticipating projecting full obligation of the Central Health budgeted revenues tied to our direct fee for service. There's some other things within the contract we have with you as our partners at Central Health that may or may not be fully realized, like pay for performance and that, but those are some other things. But from a direct fee for service, we're expecting to fully obligate that. We're on trend right now at 98% or thereabouts, and it's increasing day in and day out, given some of these things. And of note, we're surpassing our projections for our same-day on-demand services, despite the persistent clinical vacancies we've had at those sites. So just wanted to go ahead and point that out. With that stated, it's on the up and up, which is always a good thing, quarter over quarter, but we're paying close attention to this. And we've implemented new 12-month rolling, 30-day or 90-day rolling projections that are going to be helping us better understand this as well. So I'm going to hand off to Tara, my dear colleague, who's going to speak specifically and about our initiative as supported by Central Health Board of Managers around our relationship with the Black Men's Health Clinic. So Tara, please have at it. Thank you.
Thank you so much, Jason, and thank you, Board of Managers. I regret that I cannot be there in person, but I thought it would be better if I kept my germs to myself. I'm going to be speaking to you about the Black Men's Health Clinic. I think the last time I spoke before you was in December, as we kind of walked through what the plan was for the community outreach funds that were designated by the Board of Managers. We did provide a Q1 update to the executive staff as part of our regular meetings with them as we share information. And so now today, I'm going to share with you sort of year to date where we are in regards to the Black Men's Health Clinic. There is one caveat. I'm going to be concentrating primarily on what is happening within the community care clinic that is operating out of there, and specifically as well as the community outreach activities that are funded by Central Health. I'm going to leave all the other good work that clinic is doing to them to speak on their behalf and better describe the full suite of services that they are offering out of there. Next slide. So just as a refresher for you all, the Black Men's Health Clinic, which is a separate nonprofit, opened in Q2 of 2022 in March. We were in discussions with them previous to opening around what it might look like. They really envisioned a different model of care that really focused on the health needs of men of color. The board of directors recommended that we add BMHC to our HRSA scope of service, which means that it is official site within our 330 grant. At that point, it's 1 day a week, but that allowed us to go ahead and open and start providing services while keeping an eye on the demand. We started delivering services officially in June, and the Board of Managers voted to allocate $290,000 to community care to assist with personnel at BMHC related to community outreach, specifically with under-resourced individuals within Eastern Travis County, men in need of healthcare. Sorry, I am skipping around, going up and down is hard. We're able to hire a provider in Q2 of 2023 that we share at Runberg, and then the 1 day a week at the Black Men's Health Clinic. We did expand to 1 full day instead of the evening hours. Part of that, I think, as I mentioned to you before, was at the request of the patients themselves, and is something we continue to keep an eye on. The nice thing about sharing that provider is that Runberg is close, and that if there are procedures or services that cannot be provided in that smaller environment at BMHC, we are able to preserve continuity of care with the provider at Runberg if necessary. We have, and you'll see in some of the later slides, that we are still sort of tinkering and iterating on what is the best use of that site and the time that we allot to that clinic. And so we added standby appointments in Q3 to help fill out the schedule in June and mitigate some of the issues we've been seeing with no call rates. Next slide. So clinical progress. Activity in the community care clinic hasn't continued to increase. We've had nearly 375 completed visits, with 75 of those occurring in May and June. Some things to note, we have a handful of legally female or female at birth patients who are accessing the clinic that started about 2 months ago. Anecdotally, the team members say that these are spouses and partners of male patients. The team has developed scripting when people call in to make an appointment. We make the intent of the clinic known, but we are not screening out and refusing to schedule to turn female patients away. It's something we will continue to keep an eye on. And just for your information, primary diagnosis at visits track really, really closely with that health profile that we presented to you back in December of the health needs of men of color. And that's hypertension, high cholesterol, diabetes, and chronic pain. There are many more issues than that, but those are sort of the bolus of issues that we are seeing and being treated and diagnosed at the clinic. Next slide. So when we talk about no call, no show rates, this is different than cancellations. This is folks who just don't show up, and you can sort of see the trends over time. The good news, as you can see, is that we continue to increase the number of completed visits, which is the goal. But our no-show rates at the Black Men's Health Clinic is higher than what we typically see at our other sites. Right now, it is unclear if the driver for this is transportation, the location of the clinic, or the limited availability of appointment days. As I mentioned on the earlier slide, we did try scheduling standby patients, making it clear that they were not guaranteed an appointment and would need to wait to test demand. And that does appear within early results have been successful. We will continue to monitor as we determine when and how to add that second day of clinic. Next slide. And so just in terms of the demographics, you'll see here that the largest zip code that is served out of the site is 78753. That's Runberg, both on the near west side of I-35 and east of 35. That is our highest patient population overall for the system in terms of density of patients. But the other zip codes where patients are coming from are certainly some of our highest needs areas and track very closely with the Eastern Crescent. And again, here's the slide with the chart that kind of shows how we're doing in terms of gender of patients and that very small slice of female patients that we saw in May and June. Next slide. So the majority of the patients that community care is seeing are uninsured, including our Central Health MAP Basic covered patients. You'll see here that MAP Basic patients make up the largest and fastest growing proportion of patients. Self-pay is second, depending on the month. The others are filled in with some of the limited third-party payers that we have, as well as Medicaid and TRICARE. And other would be other insurances, by and large. Next slide. So we talked, I think in December, a little bit about the name of Black Men's Health Clinic and making it clear that this was really a place where men of color should be comfortable in seeking and receiving care. And so I just wanted to break out for you sort of the demographic by the patient and ethnic group and patient race that we're seeing. That yes, by and large, the greatest proportion are Black and African American men, but there is a sizable Hispanic and Latino population that is also utilizing the clinic. 20 of the visits, just of note, were by white non-Latinos. And so we are getting that traction while keeping the uninsured, low income focus across men of all races, but preponderance of men of color. Next slide. So specifically to the Central Health funded outreach activities, year to date, the Black Men's Health Clinic in partnership with Community Care, they have invoiced us for about $160,000. We did get a bit of a slow start in terms of just the fiscal year, that we were not able to contract them with them until we had hammered out what the actual community engagement strategy would look like. They were able to get up and running beginning in January, and the group is on pace to expend approximately $286,000 by year end at their current levels. One difference, I think when we talked in December, we talked about specific positions. BMHC also uses contract employees with groups including Hungry Hill, which they have agreements with, so that rather than hiring the individuals directly, they've spread the personnel cost across more individuals. That has really allowed them to staff many more outreach events than they probably would have been able to do with full-time staff. So they staff more than 250 outreach events since January, including pop-up street outreach, events at Houston Tillotson University, Manami events, Manor ISD, as well as other school districts, Juneteenth, community sporting events, church events, and Goodwill Central Texas. Another need that was identified as part of the presentation and the need for the program coordinator was to help them build the infrastructure to compete for grant funding. The organization has successfully competed for outside grants this year, in addition to Central Health funding, including St. David's Foundation, Austin Public Health, and Austin Echo. Next slide. And so that really summarizes the activities to date at the Black Men's Health Clinic, and Jason and I are both available to you for questions regarding any parts of our presentation.
Well, thank you both for the presentation and for the work you do. And I hope you feel better there, and hopefully we'll see you in person soon. I had a comment, Jason, more. We as a board, I will really interested in collaborating more with your board. And we did have an opportunity last year, or it might have been prior COVID, that we had a working work group where we interacted with your board. So our message to you, we can have something similar perhaps after our budget season or in the works, because I think it would be helpful to have these open conversations as a board, and we're actually striving for the same cause, is really improving the well-being of our most vulnerable in this community. So that is really something that a message that you can pass. And we thank you all for the work you do. And at this moment, I am gonna open the floor for any questions. Manager Jones.
Thanks for the presentation. Very informative, very helpful, and means a whole lot. I also would like to acknowledge and see if possible, we have Dr. Wallace and Mr. Wallace who are here with us, maybe to come and talk just briefly about some of the efforts that they have seen in terms of the Black Men's Health Clinic and trying to address those disparities. Is that possible?
Sure.
Oh, we have Mr. Morgan too. I'm sorry, I didn't see you there. Briefly, because we're going to be here till 12 midnight, so we don't want, but can you sort of bring us up to date on where you are and what efforts you're making to address and get men of color particularly and others to the services that you're providing. And on behalf of this board, I'd like to thank you for what you're doing. It makes a great deal of difference in terms of the disparate conditions we see in the health in our community. So if you could speak to that briefly, I'd appreciate it.
Thank you. And to the Board of Managers, we appreciate you allowing us to be here. I'm Larry Wallace Sr. This is Dr. Larry Wallace Jr., Board Chair, and this is Cameron Morgan. He's the Director of Outreach. And so we're very pleased to be here. We're not going to take a lot of time because I know you're going to be here a long time. But we appreciate the support that we've gotten from Jason and his team at Community Care. We couldn't be where we are without them. And we also appreciate the support from Central Health, because when you look at all the outreach efforts that we've made, it's because of your contribution. And we provided just a few slides for you to really look at. And it's not a lot there, but at least you have a chance to see the outreach events, get an idea of what kind of events our team is attending, and also the places where we end up going. And there's also some information, and Tara already talked about this, around race and ethnicity of our clients. And I'm really pleased to know that even though the name says Black Men Health Clinic, everybody is welcome. And almost 35% of the men are Hispanic. And so I know people were concerned, but we believe our services are so open that everybody feels welcome. And what I find out, it's not the label that matters, it's how you treat people. And when people come into our space, they are treated well. There's also gender, no surprise, most of our clients are African Americans. And so basically, our mission remains the same. We work with Community Care. We have a provider at our place 1 day a week. It's our goal to expand and have more capability. We've had that conversation and we have that commitment. And we believe that with those additional resources, we can be more successful. Our bread and butter is not to duplicate what's already there. It's really to fill that gap and create the awareness. We've done this for 1 year, and we believe we've established a foundation in the community. We have people reaching out to us to say we want to partner with you. Very strong in the faith-based community. In Pflugerville, we were at the meeting last night, and we had an opportunity to talk about a partnership with the Abundant Life Church. They reached out, say, we like what you do, can we help? And so we intend to use some of their folks from their health ministry to help us in our outreach efforts. So the dollars that you provide us are continually being expanded into other areas. So with that, I'm going to stop talking because we have a politician here to my right, former mayor of Manor, Dr. Wallace, and board chair, and I'll let him have a few words. And then I want you to know who Cameron is, and then we'll be done.
Appreciate it. And so definitely to your question, Manager Jones, our outreach and engagement, which Cameron can definitely speak more into, we initially probably really followed the same steps of every other organization, going to the health events, going to regular stuff, and we saw that was not hitting the traction for the targeted population we're trying to reach. We're trying to reach those individuals that have lost the trust, they have lost confidence in the system, that they do not are as receptive to someone that does not look like them. And so from that, just putting regular events together, giving food, giving gift cards and so forth is not going to attract them. So what we shifted to was going to regular community events, Elgin Haggai, Slice of Pflugerville, and other events like that. And that's where we start seeing a lot of the traffic and foot traffic coming in and interest. And Cameron can go into more of, we initially tried door to door. That didn't bring anything. So through his partnerships and his collaborations, sponsoring basketball leagues and bringing in partnerships with Austin Public Health and others to bring in non-intrusively concussion screenings and blood pressure checks for the basketball players before the games. They just did last week with Manor ISD Athletics screenings for the football players. And so we're trying to find these ways of enhancing the organizations and the nonprofits and the other entities that are in the community and really being a part of that community, which we have seen with our numbers. Just this 1 year, we had 100 unduplicated clients that we put down for our report for Austin Public Health. We have almost tripled that. And so just this second year going in, we're gonna go back and refocus, making sure that we're giving each one of those 382 unduplicated clients this year the care that we said we're gonna give them, because we've already tripled what we thought we were gonna have to try to get in, just because of what Larry Sr. said and what Cameron's team has been doing, but has been focusing on addressing the needs of the people, making sure that we unapologetically say that we're here for them. And in that way, unduplicating the effort, we're working with the system in a way of accountability that's mutual, while at the same time improving the system of care for those individuals. Cameron?
Absolutely. And so the key piece to all of that is developing trust. And so the key piece to all of that is developing trust through our efforts. We believe that we want to meet our client and demographics where they are. And so by doing that, we try to find areas in the community where trust is already developed. For example, our Healthy Cuts program, where individuals are able to receive healthcare appointments and get $25 off of their haircut. But we know in the community and demographic that we look to serve what the barbershop means to them, sports league and other events. And so not only developing trust through meeting them where they are, but also following up with them, helping with that continuum of care and seeing them through their care plan, and hopefully being a support and a resource to them to help them improve quality of life overall, not only for primary care, but for mental health and also social determinants of health. And so excited to be a part of this and really appreciative for you all and the support and enabling us to do what we do.
And so thanks very much. I'd just like to remind the board that when we look at the mortality and morbidity rates in this community, among our population and the general population, the leading cause of the African-American male population has the lowest life expectancy of any population. And so efforts like this focus in on trying to address that disparity. And we're not going to do it just by talking about it. We have to have people on the ground. And I think this initiative, as supported by Central Health and with the help of community care, is a model that's being looked at not only here, but also around the country to be able to address that disparity. So thanks very much for joining with us today. And I'll leave it at that unless there's other board members that may have any questions.
Thank you, Manager Jones. Thank you all. Any further questions?
Just a comment, and that is to thank you all for the work that you're doing and for the impact you're making on since nobody can hear me, right? Thank you for the work that you're doing and for the impact that you're making on your community, our community, because we're all after bringing each other up. Because only as we bring each other up do we improve all our overall quality of life. So thank you very much for what you do.
Thank you, Manager Valdez. Manager Motwane.
I want to echo thanks as well. I also appreciate the detailed report. This is really helpful, both the information the community care shared as well as y'all's report as well. I am so happy to see the growth in patients. So happy to hear the experience and the journey of how you all pivot and adapt, and a little bit of the reasoning behind some of the strategies as you go. It's really inspiring to think of the potential that we have, not only the potential, but of course what's already been realized. Wondering, and I think since it's so early days and really everybody's grassroots at this point, irrespective of where you are in the organization, wondering if y'all are hearing from patients. It sounds like what I'm seeing on a chart on page 14 of the community care report, it was this one, that showed basically, in each month what the patient coverage was, and I was noticing, and then that y'all had mentioned, of course, that MAP and MAP Basic make up the largest and fastest growing which is important for us to hear and to know that our patients are receiving care and receiving culturally competent and comfortable care at the Black Men's Health Clinic. But it also makes me wonder if you all are hearing, or if you have a sense for why more patients may not be enrolled in Medicaid and why they may be MAP or MAP basic patients, and whether it's income qualification, whether it's maybe unfamiliarity, whether it's anecdotal or statistical, whatever you're hearing, if you had any insight. But I don't want to belabor that, and that could be for anybody in the room.
No,
Go ahead.
I was going to say regarding the MAP versus the Medicaid and Medicare, we are looking at creating more relationships and being able to provide that information and coordination in our facility. One other discussion was, I know with the previous and the current leadership for Sendero Health Plans, wanting to have those conversations with them as well to be able to place out all those different resources, foundation communities as well. But we do have that 48%.
It's probably a sense of like outreach more than really. It's not a trend in the population that folks are not.
Correct.
Okay, thanks.
Yeah.
That actually helps me.
If I could jump in just a little bit on the Medicaid front, at least I know that the Black Men's Health Clinic sees all ages, but community care is 18 and up. And if you recall, given the fact that we are not a Medicaid expansion state, it is relatively difficult for adults to be on Medicaid.
Yeah, and I think what I would add to that for the Board of Managers awareness as a whole is a staggering 67% of our adult patients that are from 18 to 64 are actually, it's higher than that. It's 71%, 67% is from 18 and above. 18 to 64, 71% of our adults are uninsured, and we know that our men tend to be uninsured longer because they do not get coverage through Medicaid very often. And the main reason behind that is because they are not eligible due to pregnancy, like our women are.
Dr. Martin.
Thank you. Thank you for the very good work you did. I appreciate it. I have a question, two questions, sort of. When you go to recruit patients, say you go to a church, or you mentioned a barbershop, for example, is your ability to enroll patients like made available to them there at that moment?
Yes, that was one of the changes we made early on. You can go to events and pass out information and tell people how great you are, but they go away and they forget it. But right on the spot, we do have the capability of actually making that first appointment.
Great.
So it's real time. And so we find that that's much more effective.
Okay, thank you very much. That's a great answer. And the second one is, what are you all doing to address the no-show rate? I know that I'm a physician and that's a real pain. What are y'all, is there a methodology being approached to doing that?
Yes.
1372 with service Fort Myers, all passengers.
Hi, this is Tara. I will answer. So the no-call, no-show rate, I would say, is part of our area, although we were working collaboratively with the Black Men's Health Clinic on that. And part of it is understanding the population, which we are endeavoring to do. It's a different location than many of our other sites in the sense that there's not a lot of natural foot traffic like there is in some of our other locations. And so it's strategies like having the standby appointments and other things that our chief operating officer is working on to try and improve that.
And I would
And
add,
for the Board of Managers awareness, across most health centers in the country, the no-call, no-show rate is about 30%. Community care average is about 25%. So while higher by about 14%, we are deploying mitigation strategies to Tara's point.
Okay, because many clinics, for example, have called the day before processes or send a text message out as a reminder, y'all doing things like that, because the need's tremendous.
Yes, sir. We have those interventions in place. We also overbook. We do same-day appointments as well to mitigate those no-call, no-show rates.
Okay, thank y'all.
Thank you.
Of course.
Manager Valdez, is it quick, because we have another item.
One last observation. I'm an old lady, but I remember the desegregation and busing wars. And we had so many people that were already, they were teens, they were in high school, and they were not living with their parents. I don't think that that has changed. I think I see a lot of that continuing today, and this is 40, 50 years later. So I was wondering whether or not you were making any contacts or having meetings with the transition period from high school to graduation community, where you're making presentations, you're trying to get the kids signed up. Many of them are already 18 or 17 when they're in high school. If you could just, if you're trying to reach them at that level, so that you can hook them into going to your clinic as opposed to someone else's.
Absolutely. So we are making those efforts, working with the local various ISDs, and definitely trying to be as proactive as we can before having to be reactive and make those lifestyle changes before.
Especially with our minority majority campuses. Thank you.
Thank you all.
And Manager Valdez, I think what we would add from Community First perspective, it's one of the reasons why we're expanding our school-based health center initiative. We have a health center on the campus of Eakins, and we're looking to expand that. And we already have been selected by Austin Independent School District to operate a clinic on the LVGA campus, and we're working through that as well for your awareness. Thanks again for the opportunity to present this evening, and thanks to your colleagues at Black Men's Health Clinic for the great work they're doing.
Well, thank you all, and safe travels, Jason, and feel well, Tara, and thank you all.
Thank you.
So, moving on to Sendero Health Plans, Perla Cavazos and Dr. Mary Carol Jennings will be presenting for Sendero.
We actually have the whole executive team today. Good evening, managers.
Good evening, welcome.
Yeah, it's great to be here to give you our quarterly update, and then also we'll be providing some updates during closed session. I want to introduce, we actually have the whole executive team here today. We have Ellie Baranacci, our Chief Financial Officer. We have Dr. Mary Carol Jennings, our CMO. And we have Tira Thomas, our COO. Also on video is our board chair, Betty DeLargy. There she is. And then I want to acknowledge Betty Patterson as well, who's one of our senior advisors, and we work very closely. We're gonna proceed. I've asked the team to, be concise and hit the highlights of the slides that are in front of you. I know, we'll also have some more discussion in closed session, so we're gonna try to go through these quickly. The first slide, at the last quarterly report, some of you asked for information about board terms, so I just wanted to provide that. Second slide, what I'm providing here is just an update on where our membership levels are at in 2023 and compared to 2022 for the same time period. And we did our best at breaking down membership by different categories, which we thought you might be interested in. So I'll let you look at that. And then we were also asked if we could do a geographic analysis of where our members are. We use this graph here. We'll see how that works for you all, but we did focus on Travis County, where that's where most of our members live, and we did this graph just based on zip code. So you can see there visually that most of our Travis County members are in the 78745 zip code. Moving on. So we're going to get into, I just, in summary, before I hand it off to Ellie and others, I just wanted to hit a few key highlights for this past quarter. Actually, I don't have this slide, so I'll need my glasses. We worked really hard this past quarter to finalize our rates for plan year 2024. It was a team effort. Oh, thanks. Team effort. We had involved, also some actuaries and consultants as well, but we feel that we have very competitive rates going into next year. Those have been submitted. Additionally, we worked on our qualified health plan submission, and basically this is the plan benefit design template that, where we worked around setting the most attractive benefits and services for our members based on different metals. That was also submitted in June. This quarter, we've been also focused on doing some marketing to the population that's being impacted by the Medicaid unwinding. And so we have picked up in this past quarter 24 new formerly on Medicaid members, and additionally, in the process, we've picked up 145 other new members. We have, and we've been making progress on the joint analysis exercise, and this is a project that both the Sendero Board and Central Health Board of Managers and Central Health Leadership are, have directed as a priority for us, and Dr. Jennings will speak a little to that on the last slide. We hired a compliance director, which I'm really excited about. We had a very capable team, but we'd had that vacancy for a while, so I was happy to fill it with somebody who's very experienced and worked at other health plans, and she's jumped right in and really just been helping us get more structure, more organization, and also related to that, and I didn't put this on here, but in January we did begin our we do these periodic TDI financial exams, which it's like every 3 to 5 years they look at the company's financials and risk. And so we're going through that exam right now, and Carrie Sullivan, our compliance director, has become the point of contact and has been able to take a lot off our plates. Additionally, the CEO search progressed, and we made some progress on that too. So I'm going to stop there. Ellie's going to give an overview of our quarterly financials, and then Tiara and Dr. Jennings are going to speak to a few specific initiatives that we've been working on this quarter.
Good evening, managers, and thank you for having us today. My presentation today will be very simple. You all approved our budget last year in September, so that would be the first column that you see on the slide. The second column will be where we will be 6 months from beginning. And then the very last column is where we are today. And so the biggest thing to highlight is that the enrollment that we had projected was 10,800 members, and we ended up with 6,670, as just Perla mentioned. So the financials through June are actually better than where we will be with the budget in terms of margin, but you can see some differences. So one of them is the total revenue, which is 69% lower than what it would be from the budget. And that's just based on the decrease of membership. And then we have a higher risk adjustment, and it's due to the higher acuity of the members. We did have an increase of the CHAP expansion enrollment. And we also have seen higher acuity in our regular members. Our medical expenses are at 84%, which delineates that relationship between risk adjustment and claims is not necessarily the same. So we have been seeing lower claims, but still higher risk adjustment. And then on our admin, we're at 88%. That includes the quota share reinsurance agreement interests. We're still at 20% of the premiums, around 20% of the premiums. So we're still, actually we're at 21% right now, but still within the scope that where we need to be. So yes, the main factors are membership, and I think we're happy just to see the net income again. This time of the year, we've only had one of the risk reports populated. We try to be very diligent into getting our risk identified very early on in the year, but we still have 6 runs to go. So that would definitely change a little bit. Yeah, that's where June, where we are, and the June financials that were submitted to TEI recently. Anybody has any questions?
Thank you. Is that the end of the presentation?
Well, for me.
We've got a few more.
Okay, how about we complete those presentations?
Okay, I'm
and if
sorry.
Anyone
Yeah.
has any questions?
On the right side, okay. So this quarter, our marketing and business development teams were still busy out in the community. They went to about 51 community events. Those in June included the summer lunch kickoff program with, we collaborated with Central Health. We have Ham Loves You, and then there was also the annual Juneteenth education event that we attended. These are just a few that we wanted to pull out in the month of June. Also, we worked across Sendero to design plans for 2024 that included some of the marketing strategies that we'll talk about in the future and how we are going to obtain new membership going forward. We've also launched and are in the final stages of a CHAP survey. And so that survey was conducted by our research team, and preliminary results have shown that about 90% of this membership were satisfied with Sendero. And once that full study is completed by the research team, we will be able to share those details with you. Additional activities, continuing to stay busy. The cost transparency tool is that part of the interoperability rule that's mandated by CMS. The cost transparency tool allows members to go to our website and type in services by description or diagnosis code and put in the provider or geographic area and kind of get an estimate of how much they will be spending out of pocket. So it's a tool that's utilized by members so they know before they receive the service, where they receive the service, how much they may be paying out of pocket. So that's a requirement by CMS, and we were able to launch that successfully. There's also another part of interoperability that we needed assistance from Joint Tech for members to have access to the same information, including clinical, on their phone. So CMS has a list of providers that members can download apps and have the same clinical health, like a medical record on their phone via an app. And so we were able to launch that as well. There's one more phase for this interoperability rule that is mandated. We will start working on that in the future. It goes live in 2024, and that's the payer-to-payer. That's the last piece of this rule.
Thank you.
You're welcome. I think I have one more slide. The next is member services call center operations. Just to show a demonstration of the calls that our call center completes for us. We do outbound calls as well. We make outbound calls to our members to remind them of their premium payments. And so that's why we broke down the numbers so you can see our statistics here, and to highlight that our Our queue is less than 2 minutes, which is the metric for the industry. And I think that's it.
All right. Thanks, Tira. So I think I've got 3 slides that I'm speaking to here. So to start with the health services updates, we pulled out a couple of things we thought would be most relevant to this board and our overlap with Central Health's mission. So item 1 here, we've been working on improving our capacity to communicate with our members through assessing and updating and upgrading our texting platform. So after pausing the member texting services that we historically had in place to troubleshoot some vendor issues from Q2, we were pleased to share that we had anticipated an August go-live date of a new secure HIPAA-compliant texting platform to better serve our members and really respond to how they want to communicate with our case management and other teams. And spoiler alert, this has gone live on schedule this, Q3 this month. Next point here, we've also been working on enhancing our programs to mitigate transportation-related adverse determinants of health. And the Q2 update there is around our transportation program. We just highlight that again as we have previously. But that program has provided for Q2 over 2,000 rides to our membership through car share and also like Uber and Lyft, as well as non-emergency medical transportation services. We have, looking forward to Q3, put in place an implementation plan to expand after-hours access to those services to, again, kind of help members get to clinics and meet them where they are. Next slide. Additional operational initiatives include where I want our team to be in terms of implementing new regulatory requirements for what's known as the physician gold carding legislation around prior authorization, and also known as House Bill 3459 from the previous legislative session. We are we've got 46 providers currently exempted from prior authorization requirements for a total of 140 commonly approved CPT codes for each of those individual providers. We do, like part of the legislation, the statute is that we review those exemptions and make sure that they should have been exempted, essentially, to make sure that our patients aren't getting unnecessary medical care and that there's some checks and balances in place. So 10 of those exemptions were rescinded upon an external peer review in this last period for a total of 19 codes. So the takeaway is that this is new legislation that a lot of other health plans have struggled with, and we're up to date on where we need to be implementing that. And then finally for this slide, we've been managing our cancer care utilization with a model that really drives towards quality. So in 2022, we've briefly mentioned this in previous reports, but Sendero selected a unique partner to enhance the cancer care that we provide to our members. And through the vendor of choice, we support our utilization management team in providing expert review of proposed treatment plans, making suggestions to our providers on kind of the latest evolving standards of care, clinical trials, new protocols, and the like, and suggesting treatment alternatives to our cancer care providers through this service in a way that minimizes provider strife and helps the patient get kind of access to the latest standard of care. So in Q2, here's a chart of the kind of number of patient cases that we used this service for to oversee and ensure and assure high quality of care. And the next and last slide. This is the report out of the joint analysis exercises that Perla had mentioned. So I've run this by the Central Health leadership as well as our own leadership, and I'm presenting kind of an approved set of talking points, so we're all on board here, just for kind of the context. So at the joint direction of yourselves, the Board of Managers here, and our own Sendero Board of Directors, the leadership of our joint organizations have worked diligently over the past months to plan and stand up a series of what we're referring to as joint analysis exercises. The steering group of these joint, and so I'm kind of showing you where we are to date. The steering group of these joint analysis exercises, comprised of our senior leadership, has articulated a set of 4 objectives. I show these on the slide here. And they're all aimed at studying, articulating concrete pathways forward to further align Sendero and Central Health programs and offerings, and to optimize the services we offer to the community. So since we last presented quarterly updates to you, we can share that work is substantially underway on the first 2 prioritized work streams shown here in blue and the first half of the green circle. And so that entails that we've tapped relevant managers and frontline staff to input data, mapping network and patient cost sharing, plan benefit and service offerings, including for a selection of plans that we've agreed upon. We're going to look at plans and offerings. So that's the CHAP expansion plan, 2 selected silver plans, a representative bronze plan that's still being discussed, and then for MAP, a number of MAP programs. So 100 basic, 100, 150, basically the set of MAP programs that the Central Health team wanted to evaluate, and also for CARE chair programs that are under Central Health's purview. The second point here under the CHAP optimization workflow, we have reached consensus that we need to balance between a set of 5 factors to optimize re-enrollment. And those include a minimum risk score, a maximum risk pool drawdown, a justified premium support level, a sufficient utilization level, and a sufficient engagement in case management and the care navigation component of the CHAP expansion program. We've also agreed that we'll prioritize mapping out how our programs and our offerings can influence and optimize a patient's journey, kind of through our whole health system, like what Central Health, Sendero, and our other partners can offer over time for a group of 4 clinical disease burden cohorts. And those are, we've agreed to look first at patients with cancer, with chronic kidney disease, with organ transplant, and probably next year at patients with heart failure. And that's based on prevalence and kind of what programs we have in place that we want to concretely study and try to optimize. Those are our updates. There are basically stay tuned for discussion in closed session on how especially work group number 2 has already been able to translate into a new collaboration to fine tune our offerings to the Central Health mission and to jointly serve the needs of our community.
Thank you so much, appreciate it. So that concludes your presentation?
That concludes the presentation.
Thank you so much.
That's right.
I am gonna open the floor. Do any board members have questions? So I see none. Thank you all for your work, and we look forward to seeing you in a few minutes. Thank you. So, members, at this time, I am gonna call items 3 and 6. And item 3 is discuss impact of potential changes on the proposed 2024 budget tax rate and future delivery of health care. And item 6 is receive and discuss an update on Sendero Health Plan's financial and proposed business strategies. So at this time, I announce that we are convening in closed session to discuss agenda item 3 under Texas Government Code 551.071, consultation with attorney, and agenda item 6 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.085, governing board of certain providers of healthcare services. So, yes, so we are going in closed, right? And it is August 23rd, 2023, and it's 6:35 p.m. Thank you.
know when those individuals turn over, so we don't send somebody.
Ready?
over there,
Okay,
so they
perfect.
stop.
So, welcome back, everyone. We are back to open session. And today is August 23rd, 2023, and it is 8:07. There are no motions for the items that we discussed, item number 3 and number 6. And at this time, I am moving on to item number 7, confirm the next Budget and Finance Committee meeting date and time and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, September 6, 2023 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment.
Move adjournment.
Thank you. I have a motion and a second. All agreed?
Aye.
Aye.
Meeting is adjourned. Thank you all.
Good evening. Today is August the 23rd, 2023, and it is 8:07 p.m. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. Our first item of business is public communication, and I am told we have no one awaiting to speak for public communication. Members, because of the late hour, what I propose to do in looking at the agenda for the executive committee meeting is to not take up the agenda items as presented and move them to the next meeting. And I will read out those agenda items that we will. Don't have to read them? Okay. Okay. So, hearing that, we will put those agenda items on the next agenda. I will take up agenda item number 5, confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, September 6, 2023 at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, Manager Motwani motions that we adjourn, and Manager...
I'm not executive committee.
Oh, that's right. I'm sorry. Manager Valadez.
Thanks for the upgrade.
Manager Valadez motions adjournment. And
second.
Manager Musaitis seconds. Any further discussion? Hearing none, all in favor? Aye. Any opposed? Motion carries. We are adjourned. Okay. Good evening. Today is August the 23rd, 2023, and it is 8:09 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. Our first item of business will be the consent agenda. Consent Agenda 1, approve the minutes of the Central Health Board of Managers, July 26, 2023, and August 2nd, 2023 meetings. And Consent Item 2, receive and ratify Central Health investments for July 2023. Manager Valadez.
I move the adoption of the items C1 and C2.
I have a motion from Manager Valadez. I have a second from Manager Motwani. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Motion carries. We will now proceed to the regular agenda. Members, we will not be considering a number of items on our agenda this evening. Specifically, items 1 and 2 were covered in Budget and Finance, and on items 6, 7, and 8, there are no updates from staff from those standing items. For the record, those items we will not consider are: item number 1, receive and discuss a presentation on the proposed Central Health fiscal year 2024 budget and tax rate. Number 2, discuss impact of potential changes on proposed 2024 budget, tax rate, and future delivery of health care. Item 6, discuss updates on a performance review contracted by Travis County, including delegations to the president and CEO to execute necessary agreements between Central Health, Travis County, and Mazars USA. Item 7, receive and discuss a briefing regarding Travis County Healthcare District, DBA Central Health versus Ascension, Texas, FKA Seton Healthcare Family, cause number D1 GN 23-0. Agenda item 8, receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District, doing business as Central Health, and Mike Giesland, cause number D1 GN 17005-824 in the 345th District Court of Travis County. The regular agenda. Number 3, agenda item number 3, discuss and take appropriate action on Central Health's proposed tax rate for fiscal year 2024. Jeff Knodel and Kim Johnson will be presenting. Members, as a reminder, this item is the preliminary action we must take in connection with the tax rate for fiscal year 2024. Tonight, we will vote on the proposal to increase the tax rate to 10.0692 cents per $100 of taxable property value for the 2023 tax year, which will support the Central Health FY 2024 budget. The final vote for the Board of Managers on the adoption of the tax rate is tentatively scheduled for September 6th after the statutorily required public hearing. The date, time, and location for the required public hearing on the tax rate proposal will be formally announced in the next agenda item, which will allow staff to publish the required public notices in the newspaper and on our website. Jeff?
Yeah, thank you, Dr. Bell. Next slide. And thank you for that opening. That's pretty much the presentation. This is a truth in taxation requirement. It does require the board to approve a proposed tax rate. Doesn't mean that the rate cannot change or increase. It's a notice purpose. We will take the information on both the tax rate and the subsequent item, the public hearing, and we'll publish that notice shortly. And as Dr. Bell mentioned, we'll also approve in the subsequent item our actual scheduled public hearing. So as Dr. Bell mentioned, there's really nothing I can add. The proposed tax rate is 10.0692 cents per $100 of taxable property value, and it would be the rate that we're proposing to support the requirements of our budget. Thank you.
Okay, Manager Motwani, may I have a motion?
I move that the board approve a proposed total property tax rate of 10.0692 cents per $100 of taxable property value for the 2023 tax year, which will support Central Health's fiscal year 2024 budget.
Manager Musaiti?
Second.
I have a motion by Manager Motwani. I have a second by Manager Musaiti. Ms. Brianna Yanis will now assist me in taking a roll call vote. For a roll call vote, Ms. Yanis will call the name of each board member in attendance in alphabetical order. Each board member must indicate whether they are voting yea or nay or abstaining from a vote on the proposed tax rate. Ms. Yanis will confirm your vote before moving on to the next member to ensure that we have an accurate vote tally. Ms. Yanis?
Okay, I'm just going to go from left to right. So Manager Amit Motwani.
I vote yes.
Manager Amit Motwani votes yes. Manager Manuel Martin.
Yes.
Manager Manuel Martin votes yes. Manager Guadalupe Zamora.
Yes.
Manager Guadalupe Zamora votes yes. Secretary Cynthia Valadez.
Yes.
Secretary Cynthia Valadez votes yes. Chair Charles Bell.
Yes.
Chair Charles Bell votes yes. Treasurer Maram Musaitif.
Yes.
Treasurer Maram Musaitif votes yes. And Manager Shannon Jones.
Yes.
Manager Shannon Jones votes yes.
With that, it is a unanimous vote and the motion passes. Members, I also want to note that Manager Kitchen had to attend a family funeral and was not able to make the vote this evening, but she wanted to let you know that she was sorry for not being here. Okay, agenda item number 4, set the date, time, and location for the public hearing at which Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2024 tax rate. Monica? I don't know why Monica's name's up there. Jeff?
Okay, I'll take this one real quick. So thank you for that. This item would set the public hearing. It's setting the date, time, and location for the public hearing. That would be 5 p.m. August 30th, 2023 at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702.
Okay, thank you, Jeff. I appreciate that information. Do I have a motion? Manager Matwani?
I move that the public hearing on the proposed tax rate be held on Wednesday, August 30th at 5 p.m. at Central Health's administrative offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. A notice for which will be posted on the Central Health website and published in the Austin American Statesman.
Do I have a second, Manager Valadez? I have a motion from Manager Matwani. I have a second from Manager Valadez. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Members, before we move on from this item, I would like to emphasize to the members of the public watching that even though a quorum of the board will be meeting in person, the public can still participate virtually in the tax rate public hearing. We strongly encourage all members of the public to participate in this meeting on a virtual link that will be provided in the notice and to submit any comments through that method. Okay, members, I am going to also defer consideration of agenda item number 5 to our next meeting. Agenda item number 5 is to receive and discuss an initial update on cancer care, focusing on contracted services and future updates. Our final agenda item is confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, September 6th, 2023 at 4 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Valadez.
I move that we adjourn.
Manager Jones. I have a motion from Manager Valadez. I have a second from Manager Jones. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? We are adjourned.
Thank you, members.
Good night.
Thank y'all for being here since